I'm going to go ahead and start the little timer, and there is our panel. Thank you everyone for joining us on our Monday night, 6 o'clock. Every Monday night at 6 p.m. Central, we are going to have a topic for you. So, generally, it's going to be something interesting the first week. The second week is going to be terrain based, which is more of a cancer based process. The third week is a general topic again, and the fourth week is usually JC Elite. So that's going to be your elite athletes, your high performers, your physical career athletes, things like that, law enforcement. Next week, we're going to do something different because Major Mike is actually going to be militarying, doing Army stuff, so he will not be available. So next week, my mom Susie and I are going to be talking about healthcare costs. And a lot of you are getting, if you're on the ACA, you're getting notices that premiums are going up, things are changing. So we're going to talk about how to make choices and afford the care that you want, as opposed to getting stuck in a system where you're trapped by insurance, you don't get the care you want, and it's explosively expensive. So that is next week. That is November 24th. 2 weeks from now, I'm super excited. We are one of about 5 clinics in the world to offer a treatment called MDI, microdosing infusions. So we will be launching that. So 2 weeks from tonight, which is December 1st, I believe. Monday, December 1st. I will be presenting on MDI. So I'm fresh off a training in Houston and we are ready. And I'm looking at who is here. A lot of you are candidates for that treatment. And we want to incorporate that. So I won't get into that tonight because we're talking about polycystic ovarian syndrome, but know that something really fantastic is coming. So that being said, if you have not yet met our two other clinicians here at the James Clinic, I'm so proud. We've built a wonderful team. So the first one on board was Sara Taylor. She is a physician's assistant. We met 2 or 3 years ago now, and I've been trying to recruit her ever since. And Kate Schroer is a nurse practitioner who has had run a successful practice here in the St. Louis Metro for almost a decade. And she was working with one of my best friends when we recruited her away, and now my best friend is slugging it away in clinic while Kate's with us. So very happy to have both of them here. Ladies, do one of you have the slides or do you want me to run the slides? You're muted, dear.
Oh, I don't know. Do I just share the ones that we have?
Yeah. Mhm. You can share the ones. Well, did you get the ones from Kat?
I did.
Yep. You should be able to hit share on the bottom, and we're recording. So this will be posted. All of our webinars are posted to our YouTube channel. So if somebody you think will benefit from this and aren't here, you can share that link with them. You can tell them to check out our YouTube page. Feel free to drop questions in. I'm actually going to dark my screen out because these two ladies are going to take this topic tonight. I will be here for technical support. So without further ado, I'm going to roll
I
off.
don't know if this is going to work. Why don't you just go ahead and do it?
Okay, I have them. Give me just a minute here. Got it. Okay, so here we go.
All right. So, and I think Sarah and I had kind of chatted. I'm going to kind of start it off. So I'm Kate Schroer, one of the nurse practitioners, like Molly was saying. Tonight's topic, PCOS, this is something that is so prevalent. I know Sarah and I see, I would say for sure multiple cases of this a week at least. And as being one of the newer, clinicians to the clinic, I'm getting a lot of those new people. So lots of females kind of in their anywhere from 20 to even early 40s who have been struggling with PCOS type symptoms for a long time. So as far as prevalence goes, it's estimated to be at around 12% just within the United States. So that's roughly 1 in 10 women who are struggling with this, especially during those childbearing years. Um, you start to think about, okay, why is it so prevalent in the United States? There's a variety of reasons. A lot of it is going to do with our environment. So environmental toxins, things that are disrupting our hormones, everything from what we're putting on our body in terms of skincare, perfumes, what we're putting in the environment, as far as air fresheners, things like that, laundry detergents, and then especially to what's in our food as far as hormones, antibiotics, you name it. So lots of things that can kind of predispose people to this in terms of, and again, those environmental toxins, gut inflammation or dysbiosis, chronic just mitochondrial dysfunction, chronic inflammation throughout the body. So overall, economic burden of the PCOS is approximately around $8 billion annually. And so, you think about, okay, well, where is all that money coming from in terms of what is it going towards in treating PCOS? So a lot of it is going, for some who are struggling with infertility, they might be spending thousands upon thousands of dollars on infertility treatments. If they're struggling with, say, excess hair growth from all the excess androgen, they may be getting hair removal treatments. They may be seeing multiple providers being misdiagnosed along the way, and so those dollars add up. And then you account also for obesity treatment and then trying different avenues to get to a healthy weight, and then also just the mental health aspect of it that kind of all plays a role in that. And I think Sarah was going to chat more about the PCOS symptoms.
So this is why this syndrome kind of is a little bit difficult and tricky when you look at it from functional versus traditional medicine. I feel that most of the time these symptoms could be um, confusing or cross avenues versus endocrine system, hormones, mood disorders. So some of the generalized symptoms that we see in these females is, their body habitus is very thick around the middle. They have trouble losing weight. No matter what they do, diet, exercise, they're still gaining weight. They have acne because of the extra hormonal production in the endocrine system. They can have mood swings throughout the month, often misdiagnosed as anxiety, depression, bipolar disorder. They don't have normal sex drive or any sex drive at all because of their testosterone levels being in excess, suppressing their estrogen. They can have hair loss. They can have extra body hair. They feel fatigued, run down. And then the big thing is their periods are either missed or excessively heavy. So these younger ladies that are in bed for 2 or 3 days a month with a severe menstrual cycle, passing large amounts of clots, a lot of bleeding causes the fatigue and the low iron. And then the big thing is the infertility. So women that are in those reproductive years, unable to conceive, this is where they tend to struggle physically, but then that also takes a mental and emotional toll as well. So I bring this slide up because when you go to your OBGYN, they don't, I feel like, ask the same questions as we do, look at all the factors that can affect this diagnosis. And really, PCOS is a diagnosis of maybe some imaging on ultrasound where you can see the follicles, you can see the cysts, but not an easy diagnosis to make just looking at labs and imaging. So PCOS is a syndrome, right? Polycystic ovarian syndrome. So poly in the word, Latin means many cysts on the ovaries. And anytime you talk about a syndrome, there's many different symptoms. Breaking PCOS down is how we start to get to the treatment or the best solution for the problem. The polycystic ovarian syndrome is the identifiable factor, but that's not the cause, right? The ovaries with all of the cysts and the pain and the discomfort and the fatigue and the weight gain, those are all symptoms of the syndrome. But peeling back the layers, we're able to kind of dive into this and look at these 4 categories and figure out how to best, intervene and treat these patients on a daily basis. So the first one is insulin resistance. And we hear this term often in the general population. So insulin resistance is basically pre-diabetes. It's where insulin, which is also a hormone, I don't know if people refer to it that way, but it is an endocrine hormone that comes from the pancreas. And the pancreas secretes insulin. And what insulin does is it tells our cells to use glucose for energy. It also, at the same time, sends a signal to our liver to stop making glucose because we have such glucose available intracellularly so that we're not creating even more glucose within the liver. The opposite of that is insulin resistance. So when the cells in the human body become resistant to the insulin circulating in the bloodstream from the pancreas, this can happen for a number of reasons. This can happen, number one, because when you have chronically elevated blood glucose or excess glucose in the bloodstream, that molecule binds permanently to red blood cells. So a single red blood cell has about 1 billion binding sites. And the point of those binding sites are to carry nutrients and to exchange gas within the body by carrying it to the lungs. So basically, oxygen would bind to the hemoglobin on the red blood cell to supply other cells and tissues in the body with oxygen. In exchange, picking up the carbon dioxide, taking it to the lung for excretion when we breathe out our air. If you have elevated glucose, the glucose molecule binds to the red blood cell and it will never unattach. So, unfortunately, when you have a high glucose condition for a long time, the amount of binding sites on the red blood cell are permanently diminished. A red blood cell lives anywhere from 90 to 120 days. So, in layman's terms, it's 3 to 4 months before that red blood cell dies and is replaced with a new clean one. So when you block these binding sites for whatever reason, as Kate mentioned, with sex hormone disruptors, heavy metals, toxins, parabens, stuff that's in our shampoos, our conditioners, all these things, you leave less room for insulin to do its job. Another thing that can contribute to this is when you have the insulin resistance, the signal is missed from point A to B. So in a normal body, we would release insulin, it would move the glucose into the cell, and then that would in turn feedback loop to the liver and say, we're done, we don't need any more glucose. However, in insulin resistance, the liver never gets that signal. So it's just pumping out more and more glucose, which continues to raise the blood sugar level, which continues to bind to those sites on the red blood cells that continues this kind of cascading pathway. So as a result of that, your liver starts to store fat and it becomes less able to filter the blood and the waste products from the body. It also metabolizes our hormones. So if you clog up the liver, then even if you're producing a normal amount of hormones, it's not metabolized correctly. As I spoke of earlier, the red blood cell contamination, so the glucose permanently binding to those red blood cells, diminishing the effective carrying capacity of red blood cells in the body. This can also contribute or be contributed to thyroid disease. A lot of the symptoms from PCOS mimic low thyroid. So the hair loss, the fatigue, the weight gain. Sometimes this is misdiagnosed as PCOS when really it's an underactive thyroid. And believe it or not, the thyroid controls a lot of the liver portion of this problem. So sometimes supporting the thyroid supports the liver, which can in turn support the endocrine system. The second type of PCOS is adrenal. The adrenal glands are two tiny glands that sit on top of the kidneys. These are called our stress hormones, right? And in adrenal PCOS, you have a prolonged or abnormal stress response, which causes the adrenal glands to hypersecrete cortisol, which is our stress hormone. DHEA is our stress sex hormone. DHEA is an androgen, kind of like testosterone in the body, but it's only produced on the adrenal glands. So if you're continuously in a stressed condition or state, your adrenal glands will overproduce this androgenic DHEA stress hormone, which again cycles down this pathway where you have an imbalance of estrogen and testosterone, or estrogen and progesterone, all coming from the adrenal glands. Things that affect the adrenal glands are poor sleep habits, poor diet, poor gut health, um, physical stress, so demanding jobs, parenting, marriage, all the things outside that contribute to our adrenal glands either regulating or dysregulating. Post-pill PCOS is another one that we see. So a lot of times girls in their early and late teens start to menstruate. They're having painful periods. They're having heavy periods. And the only thing people know what to do is to put these girls on oral contraceptive pills or the birth control pill. And then, some of them decide they don't want that for their body when they get a little bit older, or now it's time for me to start my family and I'm 25 and I've been on the pill since I was 16. We stopped taking the oral contraceptive pill, and in 2 to 3 months, we had suppressed the androgen levels so long that we have almost like a rebound effect to where these start hypersecreting, and it causes a whole different kind of imbalance, which then affects the ovaries, which causes the cyst to develop. And then the last one is inflammatory PCOS. So inflammation in the body affects the entire organ system. So you can't have inflammation in one place and really not have inflammation in another place. So when you look at PCOS and the body being in an inflammatory state, things don't function properly from basically the head down. So that could be affecting, the pituitary gland, which then affects the next gland, which affects the next gland and the next gland. Inflammation increases with all levels of PCOS. So insulin resistance causes systemic inflammation. Adrenal dysfunction causes increased inflammation. So this is one of those cycles that we have to really break down and see where we can intervene to get the best outcome for these ladies. Kate, do you want to take this one?
Yeah. So in regard to treatment, there's a couple of, well, a variety of ways in which you might go about it. Um, you know, Treatment really kind of varies just depending upon what's the underlying cause, like what caused that patient to start developing these hormonal disruptions in the first place. Conventional medicine kind of pathway would normally be things like metformin, again, birth control, things like Lupron to really just kind of stop ovulation, decrease excess androgens. Really, not a lot of time is spent on things like lifestyle and environment and the gut. So that's kind of where our plan differs a little bit, where we really kind of try to kind of create a plan specific to the patient, because again, everybody's root cause is very different in terms of how did they get here, with their metabolic health. And so we kind of try to just tweak that and tailor that into figuring out the why. Is it something going, like Sara was mentioning with the liver, where we need to kind of really kind of open up the liver pathways, gut dysbiosis, again, weak adrenals from things like chronic stress. And the chronic stress, as Sara was discussing, it can be the mental health piece of it, like marriage and kids and work and all of that. But also, even patients who have maybe some ongoing inflammation from, say, other health related things. Like I know Lyme disease, I see lots of patients with things like chronic infections and things of that nature, where all of that chronic inflammation can play a role too. Weak ovaries. And again, as Sara was mentioning, does the thyroid need some support? So we really try to just, again, focus on why is this happening and what kind of things can we modify. So that could be whether it be different supplements. So supplements that can help with that insulin resistance piece of it. So berberine, alpha lipoic acid, supporting the hormones with things like inositol, DIM, ashwagandha, vitamin D, omega 3s. All of those are really great options. And really kind of working towards replacing any of those micronutrients. And then really just kind of limiting any of those environmental factors. So if our patients are getting most of their skincare through, Bath and Body Works, Sephora, places like that, and really not paying any attention to what's being put on their skin on a daily basis, even down to what you're washing your body with, what you're washing your clothes with, all of that. That's just, it's full of endocrine disruptors and parabens and just kind of all of these forever chemicals that you don't think about because they're in your day to day, but they definitely make an impact. So really trying to kind of limit that. Again, working on building up the gut, and because everybody comes in at a different point with their gut health. So looking at that as well. And then just feeding the body good nutrition, moving the body in healthy ways is kind of where we generally will start.
So this slide just kind of shows how complex this can be. So when you're looking at PCOS and you've been given this diagnosis, you've been given this label by somebody, or you come in suspecting this because you've read and researched these symptoms. This is just a little piece of confusion for everybody to go through. So just showing that the hypothalamus and the pituitary gland in the brain are the epicenter kind of for the release of all hormones. So as this is signaling release of the luteinizing and the follicular stimulating hormone, you can have dysfunction right off the bat with insulin, or the signal does go appropriately to the ovary. However, because of inflammation, weak ovary syndrome, other hormone imbalances, the ovary then can't connect that signal to the rest of the adrenals, to the thyroid, to the liver, to all the other organs in the body. So these pathways are very intertwined. These pathways have a purpose, and they also have symptoms that help us by asking you the deep questions, help us kind of walk through these and as Kate was saying, tailor your treatment and your supplement list to best kind of improve your symptoms. So real quick here, some of the key drivers that you'll see with this are the ones we talked about before. The middle column here, the hormonal effect, doesn't mean much, but the consequence. So when you have more free testosterone as a female, you may just start to have facial hair, a thickened midline, deeper voice, those kind of things. High LH. This is where those girls can't get pregnant. They are not ovulating correctly. They're having a menstrual cycle every month. They're tracking their menstrual cycle every month, but they're unable to conceive. Low FSH, you can have no ovulation at all. You're not even developing follicles on the ovary because this is so disruptive. High androgens that come from our adrenal glands. This is where they start to get that facial acne, the facial hair, and they don't hardly have cycles at all. They'll go months and months without cycles, sometimes years. Low progesterone. This is where the girls are bleeding monthly, so they'll have a couple days of bleeding, then they'll have a couple days of not bleeding. They can't track a regular cycle, and then they're kind of all over the place. So these are those, moody teenagers sometimes. These are those emotional, reactive women that I think a lot of times are just mislabeled and told they have anxiety or they have depression or they're bipolar, and nobody's taken the time to really dig in to see, maybe there's a disruption of the hormones in the body going on. And then the high DHEA, remember that's an androgen. So that kind of cycles the insulin resistance, the weight gain, and all these other pieces. So basically, in summary, PCOS is definitely not caused by one single thing. Once a part of the system fails, the entire system suffers, and that is the cascade of events that we want to try and intercede on. We want to try and interject as best we can to regulate this and to balance this out. We here at the James Clinic look at the whole picture. We draw labs. We look at your hormones. We look at your cycles. We look at your symptoms. We check back with you in a couple weeks to see how you're feeling. We want to individualize this strategy for you and keep you from getting placed on something that could have long-term effects, something that could have other side effects, and do the best we can for your reproductive health and your mental health and your physical health. So that's all I had for the for the PCOS. But now I would like to have anybody ask questions that popped into your head, or maybe somebody you know is struggling with this and has suffered from this with fertility, weight gain, um, has been placed on contraceptives, and they're not sure if they should be taking this long term. Anything that we can help you with here on the webinar tonight.
I have some questions from other avenues, so I will throw those in. If you guys have questions, you can drop them in the Q&A or you can drop them in the chat. Either way, we'll work through them and answer them. Is there ever a time that, especially if we think of teenage females, so we hear the acne and you just need to be on birth control, it's the knee jerk. Is there ever a time that it would be appropriate for young women to be on hormonal birth control outside of reproductive health?
In my opinion.
Yes.
In my opinion, no.
That's what people are here for, Mama.
Yeah, I would say that doing some research on that
Mhm.
heavily with our expansion into moving a little bit of a side piece here, hormone replacement therapy here at the James Clinic. I think in order to gather that information, you have to look at everything. The number one thing that concerns me with that is birth control is not bioidentical whatsoever. Birth control has only been studied for anovulation. So the studies say that by suppressing ovulation, you cannot get pregnant. We know that's not 100% true, right? That's not 100% true. But the second thing about that is suppressing your hormones, as you could see from that one slide, doesn't just affect your ovaries. You're suppressing things that naturally occur in the body that should be working, like your adrenal glands, like your hypothalamus, like your pituitary gland, like your liver, like your thyroid. I will tell you more than once, it has happened to me personally that I get a teenage girl in here for some other issue. I'm not going to say, but some other issue. And when I get done going through the labs and start them on some supplements, some micronutrient replacements, they come back and, oh my gosh, my period was wonderful last month. Why? So, no, I would never say I would put anybody I love or care about on a birth control pill.
How about you, Kate? Do you have any kind of a different opinion on that?
I think my opinion is pretty much the same as Sarah's. I'm a mom of two young girls, one of which was 11. And so right now, all the girls that age, from like 11, maybe younger, to say 17, 18, like they're all into skincare and some of these 11-year-olds who have like a four-step skincare routine is just kind of mind-boggling. So I get to be the mean mom who is worried about, nope, that's poison. That's poison. You're not putting that on your skin. And so I kind of talk to my girls about that in terms of it does matter what you put on your skin. And it's hard with, so much right now just from a social perspective. But yeah, I would agree with Sarah, even, when it comes to my own girls, but then also the girls that I see in clinic. A lot of times there is major room for work on the diet for sure, where their diet is it's heavy in processed foods, heavy in sugar. And then also, as a result of that, their gut is just absolutely trashed, unfortunately. And plus, too, if you look back hindsight wise, like through the years as they were growing up, maybe they were the kids that had tons of ear infections. And so they've had repeated rounds of antibiotics. Um, and so just trying to kind of teach them to kind of be good stewards of their own health in terms of it does matter what you're using on your body and, you know, getting the parents involved in not bringing these certain things into the house. So, yeah, I think it would be highly unlikely that I would use it ever.
So just to piggyback on what you both have said, actually they're synthetic, very high dose hormones to overdrive your own natural cycles. So if you look at the studies, they actually girls who are on birth control, and I don't know the duration that it needs to be, have higher rates of breast cancer in midlife and tend to do worse. So, you know, I don't think we definitely counsel older women, that is, you hit perimenopause, very young women, I should say, as you hit perimenopause and menopause, that you're going to get cancer if you take hormones, which is so untrue. But we don't have that discussion with teenagers when they get started on it. So we're missing something there. And the other interesting things that I've learned about birth control pills is it actually disrupts your microbiome and it changes who you're attracted to. And so that might be part of the relationship divorce issue. All these women are on birth control pills that change who they're attracted to, and it's messing with their pheromones and attracting the wrong people.
I've heard that too.
Hmm.
Yeah. Oh, yeah. And SSRIs. So, okay,
Yeah.
great. We have a couple different questions here. So we'll work through all of them, keep dropping them in here. Michelle asks, what age, or is there one, do you consider birth control acceptable for reproductive health? If I understood correctly, you said it's acceptable for reproductive health. So actually, I did imply that, but that's not what I meant. There's just some people there's some women who choose to do that early in life just to make life simple. I don't ever think it's a great option. I think we have a number of ways we can achieve that, desired fertility or not in other ways. So I'll defer to the ladies though, because they take care of cycling women and I do not. Kate,
Yes.
Sarah?
Yeah. I don't know that I would ever recommend birth control, even if, you were older and you were already married, maybe you had had a certain amount of kids and you were wanting to pause for a while. I wouldn't tell you no. I would explain though to you my thoughts on it and my concerns with it. Like I said, it's putting a lot of strain on the reproductive organs. What women don't understand, and this is actually interesting, is that we're born with our ovaries. We're born a day old with all the eggs we will ever produce in our life. So from the time you birth your child, that baby has all the follicles in its ovaries that it will ever have for its life. That's a huge thing to consider as we age, because once we expose ourselves as a mother to things, it can actually transfer in utero to the children. And there's some studies coming out on that too, that women that were on birth control conceived, their offspring actually have higher risk of ovarian dysfunction because of the fact they used birth control prior to pregnancy. So I'm probably not a fan of this. Happy to discuss it, but yeah, I would also probably withhold birth control throughout life because of the fact it's just harmful.
Kate, anything to add to that?
No, I think I would be the same on that as well. I mean, I think there's enough information in terms of, ways to track your cycles. And I think unfortunately there's just a ton of women out there who don't really understand their cycle, don't understand where that fertile window is, how to safely navigate around it, to avoid, potentially if that's their goal is to avoid an unwanted pregnancy, things of that nature, as far as the fertility piece of it.
Stephanie, I don't know if you want to comment. You put a comment in there about taking charge of your fertility. Do you want to comment anything?
Sure. Yeah, it's a book by Tony Wexler, and it really talks about all of the ways that you can take charge of your own fertility, track your own health with that. I think there's some really good reproductive, um, doctors in the Creighton method and stuff like that that talk about that too. But that book was very crucial in helping me figure out my own issues.
Very good.
So,
Thank you. One of the other things that oral birth control does that I've seen is women take it through their teens, 20s, and then they hit their 30s and go off of it, and their tired mom syndrome. What happens is it increases sex hormone binding globulin. So then the testosterone that they have that they need for energy and workouts and to do all the mom things and chase kids around, it binds it all up. And so they're very low T. And this is where we get into that tired mom we're giving testosterone to, because the sex hormone binding globulin is upregulated. So it's binding their testosterone and they need a little oomph and a little mojo. So that's another pattern that I've seen in the past that hits in kind of the 30s. Here's the next question. For someone that uses Bath and Body fragrance lotions, do you have safe suggestions of what to use instead?
So for me, I actually usually recommend, and this is something I use myself. There's an app called Yucca, Yuka, where I was mortified the first time I used it a few years ago when you can go on there, you can actually scan the products that you use on a regular basis and see where they rank. And it'll actually tell you what about them is so bad, in terms of is it carcinogens? Are they endocrine disruptors? What's in there? It doesn't really give you, an alternative option. But for me, I just kept scanning different items, until I found some that were nowhere near as bad. I know I have a decent amount of patients who will rely more on like essential oils, things like that, whereas like a perfume kind of option. But like candles, things like that. Using more like soy-based kind of candles with natural fragrances, laundry detergents. I mean, you know, even some of the free and clear stuff isn't the greatest. But I've got some patients that use things like, Castile soap to do their laundry, things like that. So I've got some that even use like for lotions or moisturizers, beef tallow. I've got a lot of patients that use beef tallow lately. And Sarah, I don't know if you have similar recommendations.
I use a lot of beef tallow and I use a lot of essential oils. So I think there's an oil for everything. There's an oil to make you feel good, smell good, cure your headache, your stomach ache, your toothache. Um, there's a stomach for your, or there's a oil for your gut health. There's an oil for everything. So I do try to use tallow for my soap in the shower. I use tallow for my face. You can actually get tallow dish soap, actually, and you can
Mhm.
add a little bit of thieves and then it does its thing. So
Yeah.
there's a ton of resources online if you look at Clean Source, um, tons of things that are available.
Yeah, because that's the other big thing too that sometimes we overlook is even the cleaning products within our house. You mentioned thieves, and thieves is like my go-to for cleaning everything in the house. I actually had a patient who came in the other day. She was a new patient, and as soon as I walked in the room, she smelled so good, and it caught me off guard. So I had to just ask her, I'm like, "What are you wearing?" Because it smells so good. And it was literally vanilla. She's like, "I'll be honest, I put some vanilla just in a spray bottle." And but to me, like it, I guess just mixed with her own kind of pheromones and things, it did not smell like just plain vanilla. It smelled so good. I was shocked that's all she was using.
Yeah. So one of the things that's really bothersome, like the Bath and Body Works store, if you've ever walked in there, it's just a slam of endocrine disruptors. Those
Mhm.
fragrances, that's just not safe. So I'm glad you recognize that. That's important. You have to be careful on candles, air fresheners, household products. I put a link to ewg.org. That's the environmental working group. They have different apps that can evaluate different things. And you really have to toe into that very carefully because you can get overwhelmed quite easily. So most of us don't recommend like go throw everything away at your house and like buy new, but just as you run out of things, replace with something better. And it's always one step better. It's a process for sure. So great question. Um, Stephanie has another comment in there. So, what do you guys find is the most challenging thing about these patients and getting them through this? Like, where do they hit snags and pitfalls? Where do they get frustrated? How long does it take to turn this around? Kate, I'll go to you first since on this one.
Yeah, I feel like weight for me, like the things that I've seen, just because it's one of those that sometimes can be a bit slower to see some improvement on. For some people, maybe they're 75 pounds overweight and it's taken them years to get there. And so they're kind of after 3 months, if the scales only moved maybe 5, 10 pounds, they start to get kind of discouraged. But so that's where I think the checkpoints are good to just kind of continuously be checking in with them and see where are we getting, stuck. We've got Brenda, who's fabulous with her health coaching. So for people that just need help with whether it be ideas, meal prep, just positive kind of affirmations. I mean, she's your girl for that. So, but yeah, I think for me, that's the part where they will start to get kind of hung up if they don't feel like the scale is moving fast enough. But I think too, I try to reassure them, even with, sometimes I'll get patients come in and the scale may not actually be moving, But then when we do the in-body scan, you will see, body composition wise has actually changed. Like maybe fat has actually dropped and muscle mass has gone up, even though their overall number hasn't shifted a whole lot yet. So it's kind of a easier non-scale victory to look at sometimes just to kind of keep them on track. Um, but yeah, that's what I would say.
Perfect. Sarah, do you want to address that question?
Yeah. So as I was saying before, when you have that insulin resistance and you have these glucose molecules that are permanently bound to your red blood cells, I mentioned, red blood cells live quite a while. So when you have these parabens, these toxins, when you have this hyperglucose defiled red blood cell, it's 120 days for that blood cell to kind of disappear and a new one to come into a clean environment. So I think setting those expectations as we kind of navigate this, you're not going to see. Kate always tells me it's a marathon, not a sprint, right? So we're not going to see this maybe in 20 days, but maybe in 60 days or maybe in 120 days, we're going to be looking at a different picture. But we have to give the body the support it needs to heal, and we have to give ourselves time to heal as well. So yeah, I think, I can speak to the weight portion, Kate. I agree with that, but just, setting the path for success, sometimes the journey is a little lengthy. But when you're looking at reproductive and you're looking at menstruation, we do that for a long time. So yes, the path might be a couple of months, but you're talking years of success and years of benefit. So
Yeah. Um, Question, how do you feel about using GLP-1s with PCOS?
super helpful. Super helpful. And for more than one reason, right? So um, you can say GLP-1s focus mostly on glucose control, appetite suppression. But the big thing about GLP-1s that people don't realize is this peptide, this amino acid that is supposed to be found in your body, in my body, and everybody's body, has also been altered by these same things we're speaking of tonight. So anybody who's, hesitant to GLP-1s or peptides in general, put some time in and look into this. A peptide is naturally occurring in the body. It's a chain of 3, 4, 5 amino acids that has been assembled, obviously externally, but when given to the body, the cells are very receptive to it, right? They don't have to go through our food source, digest food, digest proteins, find the amino acids. We're giving it the amino acid in the peptide chain that it needs. The number one benefit of a GLP-1 actually lies within the gut. And as Kate was saying earlier, the microbiome has been severely damaged across America. Statistically, at the beginning of the presentation, we said this affects 1 in 10 women. That's in America. Anywhere else, it's like 1 in 100 that somebody would have PCOS. It's more like 4% of their population. We are in the war zone when it comes to food, when it comes to chemicals, when it comes to all this stuff. And GLP-1s were targeted, in my opinion, by our food source. So by replacing that GLP-1, you actually tighten the junctions, decrease inflammation, and heal the gut from within. So there's many reasons I would support a GLP-1 for PCOS, but gut health would be number one. Number two would be appetite suppression. And number three would be weight loss.
Kate, anything to add to that before I ask the next question?
No, I've seen phenomenal results with GLP-1, so I'm a full supporter of that. I just had a patient recently who she has struggled with her weight for years and years, definitely a PCOS patient. Um, and she was on a GLP-1 that I just started her on 2 weeks in, and she was very hesitant going into it. She's like, I don't know. And so I really had to kind of show her the research and just talk out loud with her a bit. And 2 weeks in, I think she had lost maybe 6 pounds, which really wasn't the point. The point was she was messaging me because she's like, oh my gosh, I feel so much better. And part of it, she couldn't even really quite put her finger on it. She's like, my energy's better. She's like, I just feel really good. She was a little perplexed by that. And I'm like, yes, well, that's definitely something that we see quite often. But yeah, I mean, we've seen insulin levels drop, from the high 20s into the teens and sometimes lower, just from using a GLP-1.
Yeah. I'll do last call for questions. We're kind of coming on 15 to the hour, so we will respect your time tonight. we've got a little bit more time for one or two more questions. I do want to insert here, if you're not currently our patient, you may not be aware we offer compounded GLP-1s. So if you are prescribed this class of medication, you're getting that at the pharmacy. It's somewhere between $1,000 and $1,500. Insurance generally will not cover that for various things. Have you guys have any experience getting that covered for PCOS?
Not for
I,
that specific
yeah, no,
diagnosis.
it's not going to happen.
So it used to be we could say you're diabetic and it would get covered and they wouldn't ask us questions. Now we have to have a hemoglobin A1C, we have to have a fasting glucose, we have to have what meds are you on. So it's not quite as easy to get covered. We do have it compounded. So, and we use microdosing. So we start at very low doses. And most of the time we're keeping that. I don't think we have too many patients over 5 milligrams a day or 5 milligrams a week, maybe twice a week or every 5 days. We don't go much above that, if ever. So we're looking at 200-ish to 350-ish a month, all in. So it's much more cost effective to do it as a compound. It's compounded in our office either with B12 or with NAD. So you get an extra kick of energy either way, depending on which one we opt for. So that's really great. My last question for you, as we do the all call for last questions, is there are people out there that just aren't familiar with the concierge model yet. And so they're looking for their $15 copay doctor. What do you think patients lose by going to the traditional medical system to try to get this treated? Where do they get behind on this? Where are they better off to invest them in themselves with concierge integrative medicine right up front to get this addressed at the root cause? So, Sara, what do you see as the delays on the standard medical side?
Oh my goodness. So coming from that background, um, I think just checking the boxes. So once you give your symptoms and they maybe grab an ultrasound and they see that you have some evidence of polycystic ovarian syndrome, they start checking the boxes. You get oral contraception, you get this, you get that. And it may work for some. It may mask a little bit more of the symptoms. It may improve the symptoms. But the biggest failure of our medical system is not fixing the problem. It's just masking the symptoms. Um, Looking at who this affects, this affects women in their reproductive years. I had children a little bit later in life, so I'm going to speak on that front. I wish with all my heart that I would have probably set myself up better for childbearing years. What another thing we don't understand is that the calcium that we store in our bones stops really storing at the age of 24, 25, and then each pregnancy depletes that. So having integrative health or the James Clinic, somebody who looks at this as a preventative, as an aging process, as, like I said, setting yourself up for childbearing years and then rearing children and all the things that come with that, I think gives you a better picture of health, short term, long term, and as you age.
Thank you. And Kate, you took care of these patients in the system for a long time. So what is the difference between doing that at your old clinic and your new clinic, both from a prescriber and clinician standpoint, as well as like the patient standpoint?
Yeah. So in terms of where they go wrong, it's the very beginning. From the moment they draw the labs and they get those results back, they're already wrong. That is what I've learned so far. Meaning they are so hyper fixated on, well, this is the lab's normal range, and well, you're in that range, so your hormones look great. Rather than looking at, okay, but what's optimal? And it doesn't just stop at hormones, right? It applies to vitamin D, your thyroid, your ferritin, all of it. And so that became kind of a really big growing frustration of mine is that, you would see these patients and they've seen multiple providers. With the same complaints. And so back then, my kind of default was I would pull the hormones and then I quickly realized like, okay, I don't even really know how to interpret those, right? Like I'm doing the same thing that they were doing. And so I think, I've told Sara even that I think I have learned far more about hormones just since being at the James Clinic than I did in the 10 years practicing in conventional medicine, even just, not only just in the day-to-day practice, but some of the books that I've come across now where I think I messaged you guys the other day saying like, you mean to tell me I have been doing this wrong the entire time?
Mhm.
And just having a better understanding of, because hindsight, right? I'm thinking back now, knowing what I know, hormone wise, I'm thinking back to all of those patients who did have PCOS and that they were saying the same thing over and over. They were on birth control, they were on metformin. None of them saw any improvement in their weight. Their insulin levels were not going down. Their periods were still awful. They still had the excess androgen, so they were still getting all the facial hair and all this kind of stuff. And I think it made them feel like they were doing something, but they certainly weren't improving the outcomes. And so then the second line of defense to that was, well, we'll refer you to your OBGYN, and your OBGYN really just did the same exact thing. So,
Perfect. I couldn't have said it better myself. We'll wrap here. I'll give you both a chance for final thoughts. But as you can see, we have built the James Clinic with truly gifted clinicians, people who genuinely care about their patients, who spend hours learning outside of the clinic, expanding their knowledge base, being open-minded, being open to new things, constantly. We're constantly talking, we're constantly stretching. And it's nice to be in an environment too where patients are looking for this because they stretch us. They bring us questions that we have to dive into. So it's both, right? It's easier to do it in this environment. So, um, and we are always looking for more clinicians. So if you know anybody who's a gifted clinician that would be a great addition to our team, please send them our way. I believe these two are both booked out quite far. Our clinic is they've been very popular. So we're always looking to add other people who are like-minded, gifted clinicians, gifted team members, nurses, those kind of people. So I'll just put a plug in for that. I don't see any additional questions. So Sara and Kate, closing thoughts, and then we will end it for tonight right on time.
Sarah, do you have anything? I'll let you go first.
Well, no, I just
Or I
want to
can go.
say, it's fine. This applies to more than just your ovaries, guys. I mean, the things we kind of touched on here, I see low testosterone more now than ever. And I feel like the question that I get from, 60 and above is this never used to be like this. And it never was like this. And we never had these problems. So maybe they're, I don't want to say insensitive, but don't understand these issues. Um, this applies to hormonal health, endocrine health, systemic health. The chemicals we talked about and the effects of them. This applies to everybody, your brain health, your heart health, all of the things in the body. So take some time and do some research on your own. It's enlightening. It's wonderful to do what you can for yourself and for others. So share your information that you get too. I think that's the best way we can grow and protect each other as friends and family and society. So thanks for listening and hope to see you at the James Clinic.
Yeah, I think the only thing I was going to add is really just kind of continue to advocate for yourself. Like if that is one thing I can just stress over and over is keep asking questions, keep, just trying to look for the why. And I think more and more patients are really kind of getting to that. They don't like well, that's just because that's just why we do it kind of answer. I think more and more patients are really kind of getting more interested in that route. So just continuing to advocate for yourself. Don't let anybody tell you that your labs are normal, because they're probably not. And yeah.
Perfect. Thank you very much. Good job, ladies, on your presentation. Thank you so much for being here. One last advertisement. I'm going to stop recording.